Good morning. Greetings to all of you in the conference. I am Dr. Hari Mohan, a consultant in palliative medicine in Indira Gandhi Cooperative Hospital, Cochin in Kerala. I have been a radiotherapy postgraduate, got my degree in around 1986, and since then I was working in medical oncology, though I'm not a medical oncologist, for almost around 2 decades. At the same time, I have also fellowship in palliative medicine. I have worked in medical oncology both in India as well as in very good centers abroad. So I have a lot of clinical experience in oncology, both in hematology and medical oncology. And I feel that palliative medicine is definitely a part of the gamut of oncology management. And Onco Palliation should be a speciality because it is slightly different from the usual management in palliative care or palliative medicine. And definitely a basic knowledge of oncology will help those who are practicing in cancer. And the first one I would like to talk about is the timing of participation of palliative medicine. Generally, what we see is the palliative medicine is considered as a more as a terminal referral speciality. Like when the time comes, there is no more treatment options, the patient is referred to palliative care to be taken over. This produces a lot of angst, and also it produces a lot of deficiencies. Deficiencies in the sense, symptom management will be definitely better managed from the initial phases onwards, even for curable cases, as well as psychological counseling from the initial stages and attachment to the family. And then when the time comes when the patient requires only palliative medicine also, the physician who has been in touch with the family and the patient is not a stranger, and the patient generally does not feel that it is being shunted into a terminal specialty. So in that sense, I feel that palliative medicine should be a part of the team in oncology in treatment of cancer. I have experience in giving basic family and patient counseling during the initial periods of diagnosis. Usually the diagnosis is made by the medical oncologist and the plan of management is also taken. At that stage, a palliative physician who is aware of the oncology guidelines and what the patient is likely to go through will be a best person to counsel the family as well as patient, because one, he is a medical physician. Second, he has knowledge about oncology. He has knowledge about the possible side effects, and he has got a lot of time to answer the questions and also address financial toxicity and other social and cultural causes relevant to palliative medicine in a more relaxed way than a busy medical oncologist would do. So not that they are deficient in any of these, but an assistance of a palliative physician at the stage of diagnosis for counseling will definitely help. And my experience with more than 5,000 patients for the last few years has been that too. So I feel that palliative medicine should be a part right from the day of diagnosis. As far as symptom management go also, I feel pain management is a much non-addressed portion of oncology, especially in the early stages, uh, where conditions like stage 4 or T4 lesions of the breast or ulcerating lesions of the head and neck, oral cavity, or pancreatic malignancies, gastric malignancies, or any other ulcerating, painful malignancies. Pain management should not be restricted only to just Ultraset and or tramadol and the basic NSAIDs. It definitely requires the usage of narcotics, which can be stopped once the patient becomes better with the relevant treatment. So, as far as pain management and symptom management is concerned, also, palliative care can contribute a lot in the initial stages. And also during the diagnostic workups that are involved, which are mostly of invasive type, like, for example, bone marrow punctures, lumbar punctures, then biopsies, then central vein insertions, as well as paracentesis. All these are painful, invasive procedures, and definitely a pain management will help in those situations. Even neutropenia, mucositis, or peripheral neuritis due to chemotherapy are all symptoms which can be managed in a better way if there is a palliative medical person in the team of the oncology. So I feel that a palliative physician who has been trained in basic oncology will be a great help to the team. And it should not be a referral point only at the place where there is no other hope and then he is shifted into palliative care and equated to terminal care. Of course, that is very much part of the palliative medicine, but it can definitely be started earlier. It will be helpful for both patient as well as the uh, family, and the palliative physician can actually be a bridge between the very busy oncology team as well as the patient in communicating certain issues which the patient may not present in to the main oncologist, him or herself. So that's about the timing. Now we come to the most important symptom in oncology is, of course, the pain. Cancer pain is quite severe, and it comes under the chronic pain, which is lasting more than 6 months. It has to be treated in a different way from acute pain. And there are also issues like certain drugs cannot be used, like, for example, NSAIDs cannot be used when there is renal or liver dysfunction, or we cannot use them when there is thrombocytopenia. These are the three things which are very common in during oncology treatment, or even in an oncology patient. So this has to be seen, and then the best choice or best management schedule taken by the palliative care physician with his knowledge of narcotics and opioids, which should be used later on. Suppose if it is a curable case, or even if the patient becomes better with the treatment, the narcotics can always be tapered down, and then the NSAIDs can be, or the pain management can be stopped also. So initially, pain management is most important, because pain is a put off even for the normal treatment. It decreases it decreases the acceptance of the patient towards the treatment, and the patient has got a tendency sometimes to look for alternative forms of treatment, which will be dismal for his future because of suffering pain which is not properly addressed. We find that in a lot of cancer cases, pain is not adequately addressed, and that will be a different. And it has created the feeling that all cancers are painful, which are not so, which can be easily managed also. And the other most important thing is, of course, the peripheral neuritis, which is caused because of chemotherapy and comorbidity with the patient may have, like diabetes mellitus, etc. Peripheral neuritis is also a very debilitating symptom, and also gastrointestinal symptoms like nausea, vomiting, anorexia, constipation. These are also have to be addressed. By addressing these symptomatic issues, we are also taking a big weight of responsibility from the treating oncologist, whose main focus lies on the management of the disease, in how to change the regimes or what to do in a particular patient most suitable for his prognosis. He can focus on that and leave the symptom management to the palliative physician who is in the team. So, pain management as well as other supportive symptom management, as well as nutritional issues, as well as counseling, as well as the social causes, as well as the financial toxicity, all these can be helped, and the palliative care physician or the team can be a big support during the whole gamut of treatment in cancer. And when the time comes when there is no more benefit in continuing with the active treatment, then the patient is shifted into palliative care, and the person who is looking after him is not a stranger. He has been seeing the particular physician and the team all along since the diagnosis, and it will be an easy slip over into a different part, a different phase of management in his disease. So I feel Onco Palliation itself is a big specialty, and it needs basic knowledge of oncology. And I think all palliative care physicians should take up a small observer stint in an oncology unit to understand what's happening there. Because I think a big part of palliative medicine, whatever one says about the other things, is still cancer, where it all started. So it still continues. So I feel it will be beneficial for people who are dealing with palliative care and palliative medicine to have a knowledge of oncology. Nowadays, for doctors, free guidelines are available in NCCN, National Cancer Comprehensive Network, which is followed in India, as well as European Society of Medical Oncology, ESMO. These guidelines are available online free of cost. So anybody who is not adept in the treatment regimes can easily go through it. And supportive care is a part of all the chapters in that. So they get an idea of what the patient is likely to face and what the patient requires also. And definitely it will be a great help for the oncology team who are managing the patient. And the patient is also benefited in the sense that while the main treatment is going on, there is somebody for them to lean on, and who is a supportive physician for symptom management is also there. So in all ways, Onco Palliation is something which every palliative care physician should focus on and learn about it. And it is definitely a subspecialty, I would call it, and it will help the patient in so many ways. There are so many methods, like there is rehabilitation, like physiotherapy, like during the post-treatment days, or when there is only palliative care, how to the coordination of dietitian or a physiotherapist to combat with nutrition.